welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Madison Winstead, who is a PGY2 emergency medicine pharmacy resident at the University of Kentucky Healthcare, and she's going to be presenting on the PEACHY-O trial, which is Pharmacological Emergency Management of Agitation in Children and Young Age, a randomized control trial of oral medications.
So objectives for today will review the management of acute agitation in the pediatric population, discuss previous literature on agitation in the pediatric population, and evaluate this PEACHY-O trial and its impact on current practice. So a little bit of background here. Mental health visits by children and adolescents to the emergency department are rising in the United States. And during these visits, children may develop acute agitation, which can lead to injuries to both the patient and the staff. A multimodal approach to managing agitation in the ED is endorsed internationally, and this approach encompasses environmental changes such as dimming the lights or placing the patient in a quiet space, as well as verbal de-escalation techniques, medications, both oral and parenteral, and the use of physical restraints. But unfortunately, there is little guidance or standardization of the use of medications to manage agitation and the need to avoid restraints or other more restrictive options. Avoiding restrictive options and providing the patient autonomy may help facilitate an appropriate exam, but unfortunately, there is a whole range of oral medications that are currently used to achieve resolution of symptoms. This includes olanzapine, risperidone, quetiapine, chlorpromazine, and some benzodiazepines, but this is without any evidence for which agents may be the most effective. So there was a consensus statement of the American Association for Emergency Psychiatry published in 2019, and this was best practices for evaluation and treatment of agitated children and adolescents in the emergency department. And they provide rationales for medication use, and this includes to target underlying cause of distress, to help calm patients sufficiently for rapid assessment and treatment, and to be used in concert with other non-pharmacologic strategies that I mentioned in the last slide. They kind of give some general recommendations for medications. They recommend to obtain a current medication list and history, as this will help us avoid different drug-drug interactions and adverse drug effects, and help inform medication choice and dosing. You could consider a half dose or an extra dose of home medication if parents say that it works pretty well otherwise. And they also emphasize that oral administration should be tried whenever possible before parenteral. So of note, there is no existing prospective observational or randomized control trials comparing the effectiveness or efficacy of any oral or parenteral sedative medications in the cohort of young people presenting to the emergency department. And there's very little retrospective data as well. So one of the retrospective studies includes pharmacologic management of agitation and aggression in the pediatric emergency department. This was conducted in 2018, and it was a single center retrospective observational study that looked at patients that were less than 20 years old presenting to the emergency department with either agitation or aggression. Their primary outcome was to characterize the frequency and the medication utilization of benzodiazepines or antipsychotics, and found that benzodiazepines were used most commonly, which was 67% of the time, with lorazepam being the most common among those. And antipsychotics were used 20% of the time, with chlorpromazine or thorazine being the most common antipsychotic. So essentially, they concluded that benzodiazepines or antipsychotic therapy for acute agitation and aggression in children is safe when used as a single agent. But I do want to note here, the conclusion is safe usage and did not quantify efficacy of these two classes of drugs, but kind of set the groundwork to say that these are safe and that we are able to study it more, which leads us to our main event. So pharmacological emergency management of agitation in children and young people. This was a randomized controlled trial of oral medications. The purpose of this study was to determine whether oral olanzapine or oral diazepam was more effective at achieving behavioral containment for young people presenting to the emergency department with acute severe behavioral disturbance. This was an open-label, multi-center randomized controlled trial across 9 Australian hospitals from October 2021 to November 2023. These sites included tertiary pediatric hospitals, mixed metropolitan emergency departments with dedicated pediatric treatment areas, and also a mixed regional hospital that did not have dedicated pediatric space. For methods, they did have a public and patient involvement. So they had a panel of 4 advisors that worked with the research team to develop a study protocol. And this included critical endpoint to the methods relating to participant approach, acceptability of that waiver of consent, and materials to address the needs of families. For selection of participants, emergency medicine physicians used the sedation assessment tool score to assess level of agitation or sedation to select those participants for the study. So I mentioned this sedation assessment tool, the SAT. I think most of us are most commonly seeing Richmond Agitation and Sedation Scale, or RASS. It's most commonly known and used, but its development and practice is in the assessment of ICU type patients, and its utility in the emergency department environment hasn't undergone any studies or validations of sorts. So the SAT is a 7-point scale that's used primarily in Australia, first in the emergency departments, and then they transitioned it to pre-hospital use because of the similarity between those 2 patient populations. It's a completely observational scale that uses only 2 descriptors, which is speech and responsiveness, that can be applied rapidly to initial patient assessment and reassessment afterwards. So one of the articles Australia came out with said it took on average 7 seconds to get an SAT score. But I will note that this is a tool for patients of all ages and has not been specifically validated in the pediatric setting. Inclusion criteria were patients aged 9 to 17 years old with an SAT score of 1 or greater, which is anxious and restless, determined by the ED clinician, that they had already had concerted attempts at non-pharmacological management have failed, and that the ED clinician determines medications are required and that the oral route is thought to be the most appropriate. They excluded patients with a known documented or reported allergy or non-response to either of these medications. A parent or guardian refused either of them. If there was obvious reversible etiology, pregnancy, known long QT syndrome, previously enrolled in the PEACHY-M, and that's their second trial that's concurrently being ran, but it's with intramuscular drug administration route, and that clinical decision that alternative route or therapy is more appropriate. These patients were randomized 1-to-1 to either receive diazepam tablet or an olanzapine sublingual wafer. They dosed it at 5 milligrams if the patient was less than 40 kilograms, and if they were 40 kilograms or greater, their dose was 10 milligrams. It is important to note here that the olanzapine sublingual wafer is not the same as the ODT tablet that most of us are commonly seeing. So the sublingual wafer is placed under the tongue and absorbed directly into the bloodstream through that network of blood vessels under our tongue, which bypasses that digestive system and first pass metabolism, while ODTs disintegrate in the mouth and the drug is absorbed similarly to a standard oral tablet in the GI tract. As just a brief refresher of the PK of these 2 drugs, olanzapine, the ODT, has an onset of action of 15 to 45 minutes. So the sublingual might be a little bit quicker than that, with a duration of 12 to 24 hours. And diazepam has an onset of 15 to 30 minutes with the same duration of 12 to 24 hours. The primary outcome of this study was successful sedation, which was defined as reaching an SAT of less than or equal to 0 without requirement for additional sedatives at 1 hour post-randomization. The secondary outcomes included medication-related adverse events, length of stay, aggression towards staff, participants, or parent and guardians, disposition, satisfaction with care, and whether a participant ingested the medication assigned or not. For their statistical analysis, they wanted a sample size of 348 to meet power of 80% with a two-sided alpha of 0.05, based on an anticipated 15% difference in the proportion of patients successfully sedated. They used an intention to treat analysis, so included all participants who were randomized in the study, irrespective of the compliance with treatment, and a Cox regression for time to event outcomes. Baseline characteristics here are pretty similar throughout, so approximately 14 years of age, with a little bit more than half being female. As you can see, the SAT score is pretty evenly matched at the time of randomizations, with the majority of patients with that score of 2, so approximately 50% of patients had a score of 2, which correlated to very anxious and agitated on the SAT. They also characterized clinical assessment of cause of agitation. So I just wanted to call out the most common ones here, which was either a mental health disorder or situational crisis. In regards to their primary outcome of proportion successfully sedated at that 1 hour without additional sedatives, as you can see here, it's 61% in the olanzapine group and 57% in the diazepam group, which was not statistically significant. Some secondary outcomes listed in this table. So adverse events were rarely reported, so only about 2% in each group. And then about 10% in each group needed an additional sedative prior to that 1 hour. So the measurement time for the primary outcome. Additionally, we have the proportion of patients whom emergency clinician deemed to be successfully sedated. They had a little bit higher of a interpretation compared to that 60% of primary outcome being the score, where they thought about 75% in both groups were successfully sedated. A couple statistically significant values here on the secondary outcomes. So proportion of patients who received the weight-based dose was 85% in olanzapine and 79% in the diazepam. So not all that different, but it was statistically significant. And finally, the time to randomization to medication ingestion with a 6 minutes in the olanzapine group and 10 minutes in the diazepam group with a p-value of less than 0.001. The study authors attributed this to the fact that diazepam is a controlled substance that required 2 nurses available at the automated dispense cabinet for the retrieval of the drug, when olanzapine only needed 1 nurse to get it out of that ADS. So the authors concluded that there was no evidence that oral olanzapine resulted in greater proportion of participants with acute severe behavioral disturbance achieving successful sedation at 1 hour post-randomization than oral diazepam. So a couple strengths for this study. It was the first prospective randomized controlled trial comparing oral agents for acute agitation. So at least we're getting started on some of this research to help guide us on the best agent to be used. As well as there was external validity and generalizability. So having those 9 facilities that were different in sizes and the emphasis on the pediatric population was different. So some had dedicated space and some did not have dedicated pediatric space. Some weaknesses. This was an open label study, which introducing the risk of bias. So the providers did know which agent the patient received because it was a tablet versus that sublingual wafer, which may affect their interpretation of the level of sedation at that 1 hour mark. Reason for further sedative administration was not described in the study, so they mentioned that 10% required additional medications prior to that 1 hour mark, but it wasn't really well defined of why that happened. As well as this was really a broad age range without subgroup analyses. So ages between 9 to 17 is pretty broad and encompasses both the prepubescent and pubescent periods. And in the lack of this subgroup analysis does not kind of help us guide to determine which population, if any, would benefit more from these medications and if there is a difference between those. My final emphasis here is that 40% of patients did not reach the primary outcome, which is a fairly large amount. So impact on current practice. So this study did show us that olanzapine and diazepam are safe options for oral medication in the pediatric population experiencing behavioral disturbances. But it did show us that there's limitations on oral sedation medications alone. So with 40% not reaching sedation, this study highlights that oral medications alone is frequently not enough to sufficiently calm a patient for the amount of time required for physicians and other providers to do an assessment and workup of these patients. And a gap remains on comparative effectiveness of oral versus parenteral medications for this indication. So I am excited to see that PEACHY-M study where they are using intramuscular drugs, but it does not have oral drugs as well. So we have yet to get a study that has both options in there. And with that, I will take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.